I just want to show you statistics related to this INI November session pharmacology questions. So as before going to these number of questions and everything, this is what, if you can remember in the class, I showed you this kind of graph before starting a session, 4-day session. So in INI, as I always tell, general pharmacology, CNS, and antimicrobial agents, they play a very crucial role. That's what I always tell in the class, right? You can see the same thing here. You see, totally we got like around 20 questions we got. In that 20, antimicrobial agents 5, CNS 5, and general pharmacology 2. That means to say, in the 20, these three, those three, that includes 12 questions out of 20 from those three chapters. Again, the same thing as I always tell, if you're preparing for INI, those are the three important topics, chapters which you cannot miss. Cannot miss, right? So now let's start with these questions. Like these are all the number of, because he this time he touched almost each and every chapter, but almost zero questions from ANS and zero questions from blood. So these are the two chapters which are left actually with zero questions. Except those two, he does each and every chapter. Let's see one by one. Let's see one by one now. So the first question here, which transporter is shown in the image? In the image, he has given something is going out from interior to exterior, right? And he mentioned there is utilization of ATP. That is what he has mentioned. That is what he has mentioned, right? So now that means to say it is an active transport. In this, what is the active transport here? Definitely not a glucose transporter. That is a passive transport. Organic anion transporter. That is also a passive transport. So here, sodium glucose transporter and glycoprotein PGP. These are the two which are active transport. But this one is a primary active transport. This is a secondary active transport. So primary active transport which utilizes the ATP directly, right? So this will be the correct answer. Let's see the thing which is present in our notes. Here also, if you can see, as I told you, this is a question asked in our exam exactly last year, November INI 2024. The same image they has given. They have given, and I told you, if you can remember, I told those are the ABC which they have mentioned, and they asked the statement related question. And from the same picture, he picked this one. ABC transporter. That's what I told you, ATP binding acid protein, that is PGP, which utilizes the ATP and which is going to flex or pump out everything, right? That's what I mentioned here, ABC transporters, primary active transport. And if you can see, this is what we discussed in PGP also, right? Something it is pumping out, right? As I told you, this is also the question asked in the exam previously. So again, the topic is same, but he changed the question. So that's all about the first one. The transporter is P-glycoprotein, right? Now come to the second question. Before before going to the question and everything, let me show you a graph like from our like first edition. If you can see the same graph, the exact graph, A and A plus C, A plus C, the same thing, A plus C. The same thing as asked in the exam, like graphical part. So what he has given in the dose response graph given below, curve A, it is going to represent the acetylcholine. And what he is saying, which drug is most likely responsible for producing A plus C, right? If you see our graph, so A plus C, what is happening here? If you see, it is moving left side lightly and it is moving, it is increasing the height also. That means to say A plus C, it is increasing potency, it is increasing efficacy as well, right? It is increasing potency efficacy. So in this, what will be the C? Definitely not atropine, definitely not adrenaline. So it might be either in these two. Either it might be beta-nickel or either it might be physostigmine. So now here the answer is physostigmine. Why, sir? Why not beta-nickel, right? So what is physostigmine is doing? It is going to inhibit the degradation of acetylcholine, so that increasing the concentration of acetylcholine. If the concentration of acetylcholine increases, then definitely at that point, at that particular synapse, it is going to increase the potency and it is going to increase the efficacy as well. But if you see this beta-nickel, what it is doing, it isn't directly acting agonist. It is just producing additive effect. That means slightly it might be increasing only the potency part, but not that efficacy part. So here the answer is this physostigmine. That's what I told you. If you can see this graph here in our what you call workbook, if it is moving left side, that is more potent, and if it is moving height, that is more efficacious. That's what I mentioned here also. So it is an allosteric allosteric activator, which is activating that A. What is that A? That is acetylcholine, which is activating or increasing the A is nothing but physostigmine. That's all. That's all about this physostigmine part. Now come to the next one. Which of the following is not an ADR of this inhaled beta-2 agonist? He asked what is not an ADR. So if you see our workbook here, you can see the most common ADR is tremors. So definitely it is not an option. Beta-2 agonists, what I told you, they are going to produce a vasodilation. Obviously, that's what we discussed, like A, B, C, D. A causes vasoconstriction, B causes vasodilation. So definitely this is not an option. Yes, it is going to produce tachycardia. So yes, I told you tachycardia due to reflex action. So this is not also an option here. So here comes hyperkalemia. Here the answer is what inhaled beta-2 agonists do. They are going to cause hypokalemia. They are not going to cause hyperkalemia. That's what I mentioned here. See, hypokalemia. I told you this is what the question asked in the exam. Previously, I told you this hypokalemia and as well as hyperglycemia asked a couple of times in the exam. So again, the same thing he mentioned here also. All right. So now come to the next one here. Which of the following statement regarding dronabinol is not true? Again, this is what a bit tougher and kind of question. So dronabinol, this is an cannabinoid receptor agonist. This is a true statement. It is used for AIDS-related weight loss. Yes, it is going to promote the appetite and so that patient can eat. This is also the true statement. It is largely excreted unchanged in the feces. No, actually, it is like here the question it says in the options like if you can correct me, it is largely excreted in the feces or it's like unchanged in the feces. Like I'm not sure about the options here, but definitely this is a false option. It is not used for chronic pain management. This is useful for this AIDS-related muscle wasting or weight loss, AIDS-related weight loss, and it is useful for chemotherapy-induced nausea, vomiting. These are the two indications. Definitely, this is not an indication. It is excreted in the feces. That is true, but this unchanged part, I'm not sure about this one. It is excreted in the feces, like which as a metabolite, but I'm not sure about this unchanged part. If someone can mention in the options like what is the exact option so that I'll be knowing that one. But here it is not used for chronic pain management. It is used for only two. These are the two indications of this dronabinol. So that's all about this dronabinol part. Now come to antidote. I told you, if you can remember the last page in our workbook, this is what the last page in our workbook. I told you one question will be there in the coming INI. This is what I mentioned. That was my, if you can remember my last statement, like before wrapping the class. The last page, definitely one question will be there. That's what here. Benzodiazepines, flumazenil, just given match the following: methanol or alcohol poisoning, fomepizole, opioid naloxone, naloxone. And if you can see here, arsenic poisoning, BAL. So this is what antidote pays. This is what antidote pays as a match the following. These are the correct answers, right? Nothing much. I told you many times, INI, these antidotes are very, very, very important, what you call topic. So that's all. That's all about that antidotes part. Now come to the next one. Which are the following drugs not used? Not used in the management of status epilepticus. If you can see a status epilepticus page here, this is what status epilepticus, these fosphenytoin, levetiracetam, valproate, these are the three drugs which are used. That's what it is used. Fosphenytoin is used, valproate is used, levetiracetam is used. So not used is ethosuximide. So where we use ethosuximide, sir, it is used for absence diseases. It is used in absence seizures. So that's all. That's all about this status epilepticus part. Now come to the next one here. So he has asked which of the following is appropriate treatment. What is the treatment here? What is the condition here? Haloperidol. rigidity, hyperthermia, autonomic instability, and all these things they are suggesting of neuroleptic malignant syndrome. So we all know, as we discussed in the workbook also, neuroleptic malignant syndrome, we need to stop the causative agent and go for bromocriptine and dantrolene. So that's what. So the same thing, bromocriptine or dantrolene. We don't give benzodiazepines here. That's not a what you call first line management. And anticholinergic, definitely not. Anticholinergic, we'll be giving anticholinergic in case of drug-induced Parkinson's disease, not a neuroleptic malignant syndrome. Next, continue haloperidol. No, why we continue haloperidol? We don't continue haloperidol. So that's all. That's all about this one. Bromocriptine, very direct question, a very easy one, right? So that's all. Now come to the next one. Which of the following is not an advantage of ketamine? And here, again, this is a kind of not exact kind of thing, but based on the given options, we can go to this one. Yes, it is going to prevent the tolerance, but still, it is still in the what you call development what area, but still it is not that clearly approved one. Compared to these four options, we can go to this one. It is going to prevent this opioid tolerance. So this is what answer for this one, which is following is not an advantage of ketamine. So that's all. That's all about the ketamine part. Now come to the next one. Which of the following statements regarding finerenone is false? Is asked the false statement, right? It is a cardioprotective. Yes, it is cardioprotective. That's what we discussed. Like in diuretics, if you can remember, finerenone, it is going to decrease the cardiovascular complication. That's what I mentioned, right? And I told you that is a question asked in the exam NEET PG 2024 as well. So yes, it is cardioprotective. Next one, it is going to cause less hyperkalemia. Yes, this is a true statement. It is going to less hyperkalemia. Yes, this is also a true statement. It is going to be, when compared to epinephrine and spironolactone, it is going to cause less hyperkalemia. It produces significant BP reduction. No, it doesn't produce a significant BP reduction. This is a false statement. And here it is going to get accumulated in the kidney. Yes, it is also true. So, but comparatively, spironolactone, that is less actually. But yes, it is going to get accumulated in the kidney. So that is the reason why it is contraindicated in when GFR is less than 30. So here, this is what it is going to produce significant BP reduction. That is a false statement here. That is a false statement here. Now, which of the following best describes the mechanism of action of digoxin? Again, I told you digoxin, amiodarone, those are the two very, very, very important topics for both NEET and as well as INI. And I told you many questions are asked about digoxin, but this picture is not asked in the exam. That's what I mentioned. If you can remember that statement I given in the class, now the picture has been given. So he has given the picture, not exact picture. He has given some what you call cell membrane, something calcium channel. This is what something sodium, potassium, ATPase, and this is something sodium calcium exchanger. And he mentioned it's like A, B, C something, and he told like this digoxin. Digoxin is acting on which channel, either A or B or C. That's what he has asked. Like this against B, what is the drug which is acting? That's the that kind of question he has asked in the exam. So mechanism of action of digoxin, it is here in the class notes also we have discussed it, like it is going to inhibit sodium potassium ATPase. That's what it is going to inhibit sodium potassium ATPase. That's what we discussed in class also, and I discussed the picture also here. So that's all about this digoxin part. It is going to inhibit sodium potassium ATPase. Next one. Which of the following statement about lafutidine? So what is this one? It is a H2 antagonist. It is a H2 blocker, just like ranitidine, right? So if you can see our notes here, you see lafutidine, it is an H2 antagonist. Yes, it is going to decrease acid production. I told you it has, along with decreasing acid production, it has some other property also. What is that some other property? It is going to increase the mucus, bicarbonate, and nitric oxide production. That's what it is going to increase the mucosal blood flow. This is a true statement. Increases somatostatin release, true statement. It decreases. No, it is going to increase the nitric oxide. It is an H2 antagonist. That is also a true statement. So he has asked which of the following is a false. This one. It is going to decrease nitric oxide. No, it is not going to decrease nitric oxide. It is going to increase the nitric oxide production. It is going to increase the nitric oxide production. That's all. That's all about this lafutidine part. Now come to the next one. Which of the following drugs prostacyclin receptor? PGI2 receptor agonist used in the treatment of pulmonary arterial hypertension. Again, if you can remember from our notes, you can go to rule out options. I told you whenever name contain prost, there is a prostaglandin analog, right? Prostaglandin analog. So here we have prost. Here also we have prost. It is a prostaglandin analog, not it is not a prostaglandin receptor agonist. You can see name here IP agonist, prostacyclin, that is prostaglandin I receptor agonist. It is an antagonist, endothelin antagonist. That's all. So this is what prostacyclin receptor agonist. That's all. That's all about this one. Now come to the next one. Which are the following statements regarding Rimegepant? It is true. Is asked the true statement. True statement. And if you can see, this is a false statement. It is an antagonist. Gepant, I told you all Gepants are calcitonin gene-related peptide antagonist. Those are right. Calcitonin gene-related peptide antagonist. This is a false statement. It is not going to cause vasoconstriction. It is not going to cause anything related to vasoconstriction. It is going to decrease the neurogenic, what you call inflammation part. Next one. It is given orally. It is also a false statement. It is excreted in the feces. Yes, that is a true statement here. This is what the thing here. I told you all Gepants are used for acute attack except one, that is atogepant used for prophylaxis. The remaining used for acute, and these are the two given orally, and this is what a nasal spray. This is what a nasal spray. That's all. That's all about this calcitonin gene related peptide part. Now come to the next one. Very, very, very important. The same question asked in NEET PG 2025 as well. Very simple. HIV and TB. Which one you have to start first? That's what I mentioned in class also. First, start TB 2 to 8 weeks, and later start ART, depending upon the CD4 count. That's simple. So first, ATT should be started first, followed by ART after 2 to 8 weeks, depending upon the CD4 count. Always remember ATT followed by ART 2 to 8 weeks, depending upon the CD4 count. I told you multiple times. The same NEET PG 2025 question repeated in INI 2020, November 2025. So that's all. That's all about this TB and HIV part. Now come to the next one. Patient being treated on MDR TB present with tingling, numbness, a burning sensation. That is like peripheral neuropathy. And what is the most common, like most likely cause among the given options? Again, even if you don't know this question, let's see. Clofazimine, I told you, this clofazimine, it is going to cause skin discolorization. This is what we know. And levofloxacin, it is going to cause something characteristic area of fluoroquinolone, that is tendinitis, something related to tendon. Next one, bedaquiline. It is going to cause QT prolongation, hepatotoxicity. The remaining one is linezolid. The remaining one is linezolid, right? So that's all. That's all about all the points related to. That's all about all the points related to this. What you call TB, peripheral neuropathy. Which of the following is a causate utero? This one, linezolid. That's what. If you can see here, clofazimine. Clearly, we have discussed this one. It is going to cause either diarrhea or it's going to cause skin discolorization. Bedaquiline, it is going to cause QT prolongation and slight hepatotoxicity point, right? So I'm coming to this linezolid part. Yes, I told you because of mitochondrial toxicity, it is going to cause neuropathy, peripheral neuropathy or optic neuritis, whatever it might be. So that's all about this point, MDR, TB, and peripheral neuropathy. Next, pre-exposure prophylaxis. HIV, pre-exposure prophylaxis. This is what, again, I told in the class. Post-exposure prophylaxis, that is asked in the exam. This is what left behind a very important expected question. The same thing repeated. As we all know, that is tenofovir and emtricitabine. That's what we discussed. Here you can see pre-exposure prophylaxis, tenofovir and emtricitabine. That's what I told, right? So that's all. That's all about this pre-exposure prophylaxis part. That's all about pre-exposure prophylaxis part. Now come to the next one, cryptococcal meningitis. Cryptococcal meningitis treatment. Again, I told you, if you can remember, the first page in the antifungal drugs, I told you whether if they mention meningitis, amphotericin B, 5-flucytosine. Those are the two things I told you. Remember that one. The same thing, CNS infection. I told you amphotericin B, 5-flucytosine. Right? That's all. Amphotericin B, 5-flucytosine. He has given amphotericin fluconazole. No, we will add fluconazole after, followed by amphotericin B plus 5-flucytosine, like followed by fluconazole. But we are not going to give fluconazole like in the first instant. Next one, itraconazole. No, we don't give itraconazole. And I don't know about the fourth option. If you can recall anyone, just text me what is that fourth option here. So amphotericin B, 5-flucytosine. That's what I mentioned. If you see meningitis, go for amphotericin B, 5-flucytosine part. That's what I told you. Next one, which of the following statements regarding rifampicin is false? Yes, ask the false statement. Next, it is pumped out by PGP. Yes, I told you there is a PGP inducer. Yes, it is pumped out by what you call PGP. That is CNS PGP. Resistance due to RPO. Yes, that's true. So even if you don't know, the other part, is this, it is a false statement. Fatty food, it doesn't increase the absorption. Fatty food actually, food decreases the absorption. Food decreases the absorption of rifampicin, which increases absorption for rifapentin. Rifapentin, food increases the absorption. Food increases the absorption. So here, this will be the correct answer. Then what is the false statement? This one. What is the false statement? This one. And what, I don't know what is the fourth option. If you can recall, just text me, right? So that's what I mentioned here also, this RPO. And in PGP only, I told you it is a PGP inducer. It is going to increase the activity of PGP. Yes, right. Now come to the next one, DPP4 inhibitor, which undergoes significant CYP3A, 4 or 5 metabolism. Or in other way, he asked the question, it's like DPP4 inhibitor, like which DPP4 inhibitor we need to decrease the dose when I combine with a ketoconazole. So again, before going to the answer, let me show you the screenshot of our notes. The only DPP4 inhibitor metabolized by CYP enzymes, saxagliptin. Again, direct question. I told you this is what a question asked multiple times in the exam. This is not asked. If you can remember, this is the same question we discussed in leaderboard also. So that's all. Saxagliptin, sepsagliptin. So that's all. That's all about this part. DPP4 inhibitor, which undergoes significant metabolism. Now come to the next one. Vascular endothelial growth factor drug inhibiting VEGF. What is a monoclonal antibody? Very simple, direct question. Ramucirumab. A very simple, direct question that is. And the pembrolizumab. What is pembrolizumab? You can see it here. It is a PD-1 inhibitor, right? And if you can recall the other 3 or 4 options, just text me in my Instagram. A very direct question that is Ramucirumab. So that's all. That's all about all the points, questions related to this pharmacology. So still, if I missed any question or if there is any change in what you call question or options, just text me so that I'll correct them. So that's all about all the points related to this INI 2025 November Pharmacology Recall Session. So I wish you all the very best.